So welcome back. That was a great lunch. I don't normally eat that much at lunch. So since I know how full I am, you guys are probably all going to go to sleep now. So I'm really going to try to keep that from happening. We'll make sure that we still have some interactive exercises. Excuse me. And keep your attention here. Is that okay with everyone? This is where we ended. We were talking about tough conversations and why people don't do what we want them to. So I'm just going to pick up on that just a moment and walk through the impact message of the behavior, impact, and change. I gave you a couple of examples. We walked through. I know you have all of these. Excuse me. Hang on one second. The whole idea I'd like you to take away from this today is that you really can make tough conversations into something fairly simple. It doesn't have to be this long, drawn-out, 20-minute conversation that you walk away saying, oh, I don't have time to look at that. So again, as we walk through a few of these examples that we had looked at earlier, just want to remind you that it's a very simple tool. I can't do anything but simple, and that's why I want it to be something that is simple for you all, that you can use it. A really big part of having tough conversations is just telling yourself you're going to do it. Is really saying, I'm committed to this, I'm committed to making change, and I'm committed to actually have this happen. We practiced a little bit about how engaged are you to even want to make this happen, because believe me, disengaged leaders don't want to have tough conversations. I get that. Disengaged peer-to-peer, we don't want to. So we first have to decide if we're going to have them. Then we have to look at how we communicate. We looked a little bit along those lines of what are you coming into the conversation with? Are you there just to win? Do you shut down conversation by using yes, but? So watch your buts. We talked a little bit about that. And then the other part of it was whether or not you're a good listener. So how well do you listen even when something along the lines of conflict is brought up to you? We ended with confirm understanding, kind of that closed loop communication. And we are going to practice just one of these conversations with each other. So before we get to practice, though, I do want to make just a couple comments on email etiquette today and how much we use email, how much we communicate that well. That way I can still remember the days when everything was a typed note that you got in the mail. If you all think about that, it's kind of it's wild when you think about how much things have changed today. But along those lines of email etiquette, I would warn you to never have a crucial conversation via email. I know I used to do that. I don't do it anymore. Sometimes I might communicate something to someone that was a really tough conversation by email. And what I know today is I was being a coward when I did that. I have to have crucial conversations face-to-face. What emails are really there for is just to convey information, to keep others informed, and really just as a communication tool. They're not for debate. So if you ever get into an email string, have any of you ever done that, where you're on like page 25 of the email and there's a debate going on, pick up the phone, stop, pick up the phone and talk to the person. They're not for drive-by shootings, where you kind of just gun somebody down and really can almost devastate someone in emails. As I said, pick up the phone, talk with them face-to-face. Don't ever want to lose that part of communicating and great leadership as well. So a big part of what we want to think about today is when you're having a tough conversation is that we are coaching. We're coaching if you're a leader. We are giving peer-to-peer feedback if you're not that leader, but it's your counterpart, someone you work with. To really get away from that whole idea of this is criticism and that we're saying that you're doing something wrong, it's in that whole vein of let's all be better, let's all improve. If any of you have seen Rich Bellini's book, Oh No, Not More of That Fluffy Stuff, in his book he talks a lot about how we need to be swim instructors today as leaders, that we want to teach others how to be even better instead of being leaders that throw the life or the raft out there, the, oh my word, I can't even, what am I saying? No, that's Frisbee. The lifesaver. That's exactly that. We're not the lifesaver to just save people. That we're there to coach to make, again, all of us better. The clearer you can be, particularly as a leader, really does create more trust in an environment. And if there's one thing we need in healthcare today, it's that we can trust the people we're working with. We can trust our leaders. I did have someone tell me at the break, and it's a really good point, a very good point. Engagement is very much a two-way street. You have to have an employer that wants to, or an organization that wants to really be there to create a great culture and environment for their employees to want to work in as well. That's why we teach things like rounding, a culture of recognition, looking for what's going well. All of those things roll into an engaging environment. At the end of the day, people leave an organization because they felt that their boss didn't care about them. That's really who you leave. I think we saw that one statistic earlier as well. So to review so far with tough conversations, we've talked about what are you there for? Are you there just to win? Practice presence a little bit around listening and clarifying expectations. So we are going to just briefly practice one. When you walk into any performance conversation or any tough conversation, I'd ask you to think of this. Before you begin, if you had this really turn out like you'd like it to, ask yourself how you really want it to end. What's your goal in talking to this person? And always thinking of the receiver as well. Might be hard for you to give the feedback, and it might be difficult for them to hear as well. I know I've actually said that to people before. This is going to be a tough conversation. It's going to be a hard message for me to even deliver. But because I want you to be successful, I really need to give you this feedback. So one of the biggest things you have to do when you're trying to give tough conversations is plan them. Plan them and then practice them. We highly recommend you never go into a tough conversation without at least thinking through it and kind of what you're going to say. So remember, you only have those three things. Here's the behavior, the impact, and the change I need to see. But we would like to, and if I had a lot more time, what we do is basically practice conversations around something that maybe you're going to have to speak to somebody about, or you should have spoken to them about, or you've got something come up, or maybe even one you did have that went really, really well. So working together, we're just going to take about 5 minutes. I'd like, again, for you to get just a peer or a coworker, somebody beside you. Again, if you don't like who you've been working with, change it out. But I would like you to think of some type of conversation that might be a tough one that you need to have. It can be a personal one. It can be in the workplace. Can really be anything. But what I'd like you to do is, we have a template in a format that is essentially just in this version that has just behavior, impact, and change. And we highly recommend that you take the time to kind of write down your thoughts before you actually have a conversation with somebody. The one thing I know about these is the more often you have them, the easier they become. But it's just like anything else, whether you're playing the piano or whatever you're doing, without practice, you don't get better. So tough conversations are all about making sure you think about them, but you then go ahead and execute, just like I didn't do this morning with my walking. You can think about it all day long, you can visualize it, but you still need to go actually have the tough conversation. So let's go ahead right here. I'll just stick with this one. Pick your person who you want to work with. And I'd like you to think of a situation, and again, we're not going to take a long time, just maybe 3 to 4 minutes. Think of something that maybe just happened to you at work. You can even do it if you want to think about you just saw somebody not wash their hands when they took care of a patient. if that one's easy for you or easier. But anything that might relate to either healthcare or something, like I said, on a personal level. I just want everyone to at least be able to kind of walk out of here with you practiced at least one little piece of it. So just a couple minutes, about 3 to 4 minutes, and let's practice using these 3 steps. Here's what I saw. Here was the impact. And let me show you again a couple examples because I think those are helpful. These were a few examples. When you walk past trash in the hall, the impact is our patients don't think we care about our environment. I need you to assist in keeping our hospital clean. When you don't acknowledge a patient by name, the result is what? And here's my expectation. So just a few examples. Just have literally one conversation with your the partner right beside you, or again, somebody close to you. How's that? Okay, let's come back. I know this is tough to do in a big room like this. I just noticed that you didn't wash your hands before you took care of my mother. I'm afraid my mom's going to get an infection here when you don't wash your hands. Would you please wash your hands every time before you take care of her? As a patient or as a family member, did I just walk through that pretty quickly, those 3 steps? Do y'all feel like this is doable, these 3 little parts of how you call something out respectfully? Now what I want to ask is, and you don't have to raise your hand, but I want to ask how many of you will walk out of here today and have the guts to do some of these, to actually have the guts to use these 3 simple little things in a respectful fashion. I believe if every single one of you in this room would start using something this simple, just in this room we could change healthcare right here in Indiana. I absolutely believe that. So I'm asking you to look at yourself in the mirror and personally reflect if you can make this change today. And what I want to also tell you is very, very often, and again, this is from my friend Beth, you have colleagues that are very good at this, very, very good at it. And as I said, you won't feel comfortable walking out of here today if you avoid conflict like the plague. You just can't stand conflict. You're not going to feel comfortable today. You have to practice it. But you already have some colleagues that are pretty good at this. And I would seek them out. I would seek them out and say, help me be better at this. You're so good at this. Renee Maeda is our advanced practice nurse in labor and delivery. And she is unbelievable at her communication skills, at being able to negotiate, facilitate. I don't care what the situation is in terms of conflict. She is so good at doing it. She is one that we always say, go have Renee help you walk through this. Renee has become literally almost an expert on how to walk through tough conversations. You need to have experts in your areas, in your departments, and if you're a leader, you have got to get better at this. Because one of your biggest roles as a leader is making others better, those that report to you. You're always looking for a succession plan. You're always looking for the person that's going to replace you, and you want them to be even better than you ever were. I already have my succession plan in place of who's replacing me at Sarasota. Going to be 1,000 times better than me as a leader. So just in summary, to kind of move, we're now going to move into the high, solid, low conversations, but having tough conversations, monitor your motives. Are you there just to win? And if you shut down communication, watch your butts. Never underestimate that power of negativity. You always want to value the relationship, whether it's the patient, the customer, whoever your customer is, whether it's your coworker, your peer. Listen with your body. Really remember that you're looking for eye color. Do you know the people that report to you what color are their eyes? It's a brand new test for you to start deciding whether or not you really have presence and really are a great listener. Clarifying expectations. I firmly believe this. Most times people don't do what we expect them to because we haven't told them what we expect. I think most people come in every day wanting to do a good job. They just need a lot more clarity around what is it that we expect. And particularly as a leader, that's our job. That's our job with all of you brand new nurses sitting down here, that you know exactly what we expect today. I know you're getting that from your instructors, from your professors, but we all need to be giving that to you when you come into the workplace. And then lastly, practice, practice, practice. They get easier and get easier and get easier. I'm going to tell you a little story after a bit about a nurse named Heather who was a low performer. I'm going to walk through how you have to have these tough conversations, and that the more you have them, the more they become part of your culture, that when you don't have them and when you permit things to go on, what you'll find is that it really sticks out now in your culture. Once you have standards of behavior, remember, that's the basic foundation. I would take, and some of you may not have standards of behavior or how you're expected to behave in your organization. Guess what? That's okay. I would still do them in your own department. I would still say, let's look at how we want to treat each other, how we want to behave in labor and delivery. You can still do it wherever it is you work, particularly if you're the leader. You're the one that's setting that culture. So tough conversations are just that. They take courage, but they have to be done today, especially if we want to make healthcare better. We were talking at lunch, and it's so very, very true. We have come such a long way in healthcare, particularly the last decade. I think we've made great strides. A lot of it's being pushed with a lot of changes we have, one of them being transparency. Once all of our results are out there, it pushes us to be better. So please don't misunderstand me. We've made so much progress. I've told you some of the terrible things I've done and said, but today we're getting there. We're making changes to really make healthcare better. I have some resources listed there if you want to look at those later from Tough Conversations. I could work on that all day long, but again, my message to you is you have to have them. You have to. So let's move now into from Tough conversations, those 3 steps, behavior, impact, change, are basically day-to-day coaching. It's what happens all day long, just things interacting. What we're now going to move into is what I like to call an investment conversation. An investment in really looking at changing the performance, moving the performance in your whole area, your department, maybe your whole organization if you're the CNO, the CEO. And we call them high, middle, low conversations. Actually, middle, we got a little pushback over the years. We've had people literally say, I'm not a middle performer. I don't like that term. So we've kind of switched it middle solid, that you're kind of, you're a solid performer, but you've still got some coaching that needs to be done. We'll walk through each one of these and kind of what they look like. So in the book, Culture of High Performance, Quint refers to this as really closing the gap, and that's right here in this middle part with aligned behavior. And I told you that middle bucket for me, when you talk about behavior, it's all about culture. We spend an inordinate amount of time at the student group helping organizations change their culture, move their culture to one that is more respectful and, frankly, safer. So in the performance management part of the behavior is where we get into these high, solid, low conversations. And what you're literally trying to do, the basic premise, is to move everyone's performance. So let's walk through that a little bit. But starting with, if you really want to be, the new buzzword out there today is a highly reliable organization, HROs. And what does that mean? What I can tell you is highly reliable organizations are full of very accountable, very responsible employees, and particularly leaders. And where we've seen it over and over is really the reluctance to address low performers can keep you from being the best, can keep you from really moving forward if it's not something that you're comfortable doing. So let's look at what we kind of refer to as the bell curve, and I'm not going to tell you that it's the same in every organization, but somewhat along these lines. In the middle there, you see 60% of your staff of an organization is going to be middle solid performers. You're going to have about a third of them as very high performers. They're generally your leaders, but they don't have to be, it can be informal leaders, but you've got high performers that are just, again, we're going to show you a definition, but that they're always pushing the organization. Where you hope to be is only around 8% is on the low performer side. If you're a lot higher than that, you're going to see that you're not going to get the results that you're striving for in your department. So let's break that down just a little bit and talk about what these 34% over here, what is a high performer? What would that person actually look like? And then we're going to talk about the conversations that we're going to have. Let me start with kind of queuing this up, though, first. Our goal is to move performance across this whole bell curve. So your goal is to move the high performers to an even higher level of performance. Then the goal is to move your middle or solid performers to an even higher performance. And the last goal is to either move your low performers up, coach them up, or coach them out of your organization. And we start with, it's very methodical how we do this. You start with the high performers first. And the reason we want to start with high performers is, for the most part, we rarely talk to high performers. We rarely go out and thank them for all the things they're doing. We rarely tell them the great job they're doing, that we're basically re-recruiting them on almost not a daily basis, but that you're re-recruiting them, want to have them stay engaged and stay in your organization. We don't spend a lot of time with them. The middle or solid group, so we're going to start, let me go back. You're going to start with the conversation with your high performers. You're literally going to isolate them. We're going to walk through who those people are. You're going to isolate them first, and you're going to call them literally one by one, if you're a leader, into your office and have this great conversation. As those high performers walk out, and they've now had a conversation that they probably haven't heard for many, many years with you, the leader, the boss, they're going to walk out and they're going to be feeling pretty good. They're going to be feeling pretty good because they know where they stand with you as the leader. They know where the organization's going, and they're very aligned with the direction in which you're moving. Then you go back and you start with those solid performers. Now remember, these are investment conversations. Because you may already be saying, I don't have time to have this kind of conversation. Believe me, this is an investment of your time, but it will pay off. It will help move performance. So after you've talked to the high performers, now we're going to pull the solid performer in one at a time. We're going to have a conversation with them that I'll show you in a minute that basically you're still re-recruiting them, but you've got one thing you're going to coach them on that would make them even better. Now they're going to walk out going, okay, I know where I stand. I'm good. I got one thing I need to work on. But all of a sudden, if you look at this, you've got 90% of your staff that are working with you and moving in the same direction you are. Here's one really key point about these conversations. 90% of them are going to be positive conversations. And in healthcare, we rarely take the time to do that. We rarely take the time to really go out and look for what's going well, which is, again, it's a whole shift in healthcare. We go out and look for what's going wrong because we're looking for a diagnosis. We're looking for how we can fix you. As an old ER nurse, I never had a patient come in and they came in and said, you know, my left foot hurts. I never looked at them and said, well, your right one's fine. I mean, we're always looking for what's going wrong and what we have to fix, right? This is a whole different mind shift. This is all about taking the time to have conversations with what's going well. Then the last group that we're going to look at are these low performers. And make no mistake, your low performers have already seen that one by one people are having conversations with the boss. Believe me, they always know what's going on the unit. Would you all agree with that? It's not always good that they always are, but they know what's going on. So now they're not quite sure what's going on. We purposefully do not start with the low performers because they'll sabotage this whole process. You want to have the high and solid performers moving with you and aligned with you. You got 90% of your staff knowing where they stand. Then you pull those low performers in one at a time. Just like probably most of you, my gut was at the very beginning, well, I'm going to start with the low performers. I'm going to get rid of them. Where you really want to go is to, as I said, have most people coming behind you and moving with you. So that's kind of the sequence of how this works. All right, so let's talk about a high performer. And I want you to think about this for yourself. Let's say that you do not have anyone reporting to you. Let's say that you're not a leader that does evaluations. So then I want you to think about yourself up here. Are you a high performer, solid, or a low performer? You decide. You think about your own level of performance. Comes to work on time, good attitude, problem solves. When they're on, you feel you're relaxed. So some of the leaders in here today, I bet when you're out today, you've got high performers working. And you feel fine because you know who's working, you're good, things are moving right along, everything's working well. They are the ones you would want to have peer interview others that are coming in to work for you. You want them to be peer interviewing or looking for new nurses to work with or new candidates. The professionalism. They always look at policies. They don't make personal phone calls. They're not absent, don't have a lot of absences. They're very reliable, very dependable. In terms of teamwork, they're going to always want to make things better. And they're looking at the whole organization as a whole. They would never do anything, again, let's go back to that, connected. They're connected to their department, their team, their organization. Most of the time, the high performers have an incredible level of knowledge and competence. They're seen as leaders in the department just because they're very good at what they do. People look to them for really anything. They ask them for advice. They're preceptors. They're mentors. They're just extremely competent. Their communication skills are excellent. And here's one great big thing that they will do is they don't do we, they. You won't see a high performer bash their peer. You won't see a high performer talk about another nurse in front of the patient or talk about another department in front of a patient or family member. That's just not who they are in terms of their professionalism and what they do well. And then lastly, they're very focused on safety. Remember that graph I showed you in terms of engagement and being safe employees? They always are looking for what might be the next thing that's going to go wrong. They're looking for that near miss. They're looking for how can I make this place better. High performers, here's a key, want to be on a high-performing team. That's what they want. They're winners. They want to always get better. Kaiser Permanente, we worked with them for quite a bit. Well, we still have them as a partner. And I got to work with them actually for a whole full day. We spent an entire day around this because they wanted their leaders to walk out and be very proficient at being able to do these conversations, to actually deliver them. They came up with some of their own questions, and I love these questions. Love, love, love them. Knowing what you know today, would you hire this person? Of course you would. And are you comfortable being away when you know they're in charge? And what you'll see later is what happens when the low performer, when you're on vacation. You'll see what happens there. If you were starting your own business starting tomorrow, if you're going to leave your area, leave your organization, start your own business, who are you going to call and try to recruit out of there? That's how you know they're a high performer. So you already know you can trust them implicitly. You want them on your team. They would help your own business move ahead quickly, light years. So I want you to, if you're a leader, kind of be thinking about, yep, I already know who these high performers are. I can already tell you who they are. Now I'm going to give you the definitions of a middle performer, solid performer, and then we're going to talk about the conversations themselves. So a middle or solid performer, they're still the backbone of your organization, absolutely the backbone. They're a very good, solid performer. For the most part, they have good attendance, and they're loyal most of the time. Sometimes they just need a little bit more experience. They want to do a good job. They'll bring you problems, but they may not always already have the solution or figure things out. They aren't quite at that point yet. Professionalism, they usually, there's the key word usually, if anybody knows anything about HCAPs today, HCAPs to the patient, you don't get any credit for anything but always. This always happened. So your middle or solid performer usually adheres to policies. They're committed to improving their performance, but it may really require some coaching on at least one thing to really get them to fully execute or be even better at their performance. They're, for the most part, invested in their professional development. Their communication skills, occasionally they'll use we-they language. And they can get stuck in that. And lastly, for the most part, they demonstrate safety awareness. What I like to think about with middle and solid performers, and I want you to kind of, again, think of yourself this way, is a middle performer, solid performer, if they're working on a day when there are a lot of high performers on, you'll see their performance step up. They'll go right up with, and their performance will be even higher because they're working with a group of high performers. Now, if unfortunately they're working on a day when you have quite a few low performers, which I hope I'm not a patient with you all when that's happening that particular day, if they're working with a lot of low performers, unfortunately they can get right sucked into that. They can get right sucked into negativity. They can talk about each other, get the gossip going, all kinds of stuff, because they're kind of right in the middle. They can go kind of either way. Does that make sense? A high performer is not going to let other people influence them. A middle performer will. So this is what Kaiser said. I love these questions. So we'd probably still hire him again, but there would be a yeah, but. Here's the but. Do they demonstrate consistent performance, especially when dealing with low performers? The answer is no. And here's a really big key. Are they open to coaching? Are they open to feedback? When you give them those tough conversations that we just talked about earlier, do they push back and go, I don't know what you're talking about? Or do they say, I appreciate that. Yeah, I can see that. I can see how that could have happened, and I can see how I need to change that. Again, I'm going to ask you, where do you fall here? Are you open to feedback? A high performer, a middle performer wants to get better. They want to. They have self-awareness. They know that they can always be better. And again, I kind of said this at the beginning, that if there's anyone in this room that thinks right now today there's nothing you have to learn and that no one can give you feedback that will make you better, come talk to me at the break. How's that? All I can tell you is every single day I'm learning, and I know that I can always be better. I know that I can always improve. All right, and finally, the low performer. So this is the one that many of us are able to kind of picture in our minds. They point almost everything out in a negative way. They will almost always position leadership in that we-they. Well, if only our boss would fill in the blank, stick up for us. If only something around here would change. They're very passive-aggressive. They often think that the leader is the problem. I'm going to give you an example of that in a little bit. Their professionalism, kind of that picture of Nurse Crabby back there. They don't communicate very well. They often are absent. You might have them be out or on a longer break. Have you ever thought of those? Handles personal phone calls in a manner that interferes with work. Definitely not a low performer, right? A high performer would never take a personal phone call in front of a patient. They would just not do it. Wouldn't do it. Teamwork. This demonstrates little commitment and shows little interest in improving their own performance or the performance of the organization. Low performers are the ones that you literally have to say, I think you need to go take this class. Or I think you need to develop X, Y, and Z, and this is what I'm telling you. It's non-optional. You have to do. Is that ringing any bells with anybody? Their communication, they use language, again, to create we-they. They might not provide feedback. But if they do provide feedback, guess who it's going to be. They're going to go behind someone's back and do the gossiping and talk that three-way communication. They are experts. They're masters at it. And lastly, they have little regard with safety. I already showed you that. They're the ones that are going to do the workarounds. They're the ones that are going to not follow your policy, and all of a sudden your patient is in harm's way. That's what the low performer will do. So these are the questions from Kaiser. Love these questions. Absolutely love them. Knowing what you know today, would you ever hire them again? Heck no. Have you ever met, you've got some people, I literally, in our areas, one of our clinical managers literally said, when she went into this different role, who hired these people? Literally, who hired them? So if you're already saying, I'd never hire this person again, you know you probably got a low performer. If they resign tomorrow, would you do a happy dance? Is that what everyone would do? You know you got a low performer if that's pretty much where you're thinking. Here's the next question from Kaiser. Does this person bring down the rest of the department? And literally when this person is on, can one person change the dynamics of the whole department when they're working? Okay, I'm going to push back here for a minute and say, wow, have we ever given them a lot of power? Haven't we? They can change the whole dynamics when they're working. One way you might know as well is, and for those of you, I'll just look at the brand new nurses since I know you're not leading anyone yet. One of the ways you know, and this I can remember working in the ER, this is what I used to always do, and this is back in the days when the schedule was printed, and I don't know if you still post the schedule every day or not, but we had ours back in this little corner, And I would literally go to, the night before and see who I was working with the next day. And I can remember looking at it, and if somebody would have had a camera, it depended on who was working the next day that I would either go, woo, yes, it's going to be a good day, or would I go, how can I call in sick? I mean, that's, again, how you know you've got literally a low performer. Does this person know how to improve performance temporarily? Have you ever seen that? Then all of a sudden they go back to old behaviors. Anyone ever, does that ring a bell at all? And again, I'm going to tell you a story about that in a minute. And here it is. If you were on vacation, are you more comfortable if they're also on vacation? Isn't that a great question? I love these questions from Kaiser. And if any of these ring a bell, and you're a leader in the room, and you got a little bit of a gut feeling of, doesn't feel too good, good. That's the first level of self-awareness. That's the first thing in terms of change of, I want you to have a little sense of urgency that you might need to do something with that. That's the first step. The other classic that Quint actually has said for many, many years for a low performer is, he said, the classic definition of a low performer is they even complain about free food. Have you guys ever done that? You get free pizzas, and you hear somebody going, well, nobody asked me what kind I wanted. I don't like pepperoni. Why'd you order pepperoni? Then take the pepperonis off. It was free. Don't eat it. How's that? Is that what you ever want to say? If you have anybody complaining about free food, I want something to go ding, 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 ding. And if you're ever complaining about free food, something should be going ding, 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 ding. Now, I'm going to tell you a little story about someone that fits this to a T, what's behind me here. When I first went back, as I told you, from magnet and service, I went back into operations. I went back to, I was asked to do women's and children's because, frankly, women's and children's was a mess. And I love to clean up messes. I love it. It's just great. Because for the most part, when you have a big mess, what did you have? You had a lack of leadership. You can always take it back to that. Always. I'm convinced. So as I walked into, we had labor and delivery, high-risk antepartum, we had the NICU, we had mother-baby, pediatrics, and our OBECC. So those were the areas that I'm now responsible for. The two areas that stuck out the most were labor and, of all places, mother-baby. And I want to ask, what is the one area in a hospital that should be joyful? Having a baby, right? We're the only place that it's not disease-oriented. It should be full of joy. And we had some of the most unhappy people I've ever met in my life. So as I became the new leader for Women's and Children's, I went out and immediately started rounding and meeting a lot of people I didn't know. And again, the stories that you'll sometimes read in Quint's books, I said, oh, that doesn't really happen. He said that he's run into people, often low performers, that you'll meet them and they'll literally do one of these. Look at you like this and go, oh, you're the new boss. I met Heather, and that's exactly what she did to me. She said, oh, you're the new boss. I'll outlive you too. Said that to my face. Now, how many of you would say that to a brand new leader? Your brand new boss. Do you think that's a little disrespectful on any level? I'm not a leader about power or authority. That's just not who I am. But I don't care who you are. I immediately filed that, okay? I got that here. So as we progressed, I met a lot of people and, was really trying to kind of get a handle on what was going on. One of the things I noticed was that in labor and delivery particularly, almost everyone communicated with sarcasm. Nurse to doctor, doctor to nurse, nurse to nurse. And I don't know if you know what sarcasm is, but underneath sarcasm is anger. It was a very angry culture there. Now again, we're giving birth, okay? Are you all getting this? It's ugly. So Heather, I meet Heather that first day, and about, I don't know, maybe 2-3 weeks later, I decided, after meeting a lot of people, and particularly also in Mother-Baby, where Mother-Baby kind of turned out to be, they're sort of their own island. They want to vote you off the island, and they certainly don't want you coming on their island. You talk about being resistant to change. There were what I would call dug-in donkeys, man. They didn't want to change anything, nothing. And those days of not being efficient, not even simple things like flexing to your volume, none of those things were really carrying through in terms of accountability. So I ask, have you guys ever heard this term? I just heard this last week. It's called, instead of volunteer, you were voluntold. Y'all, anybody hear that term? I love that. Voluntold. But I had a tough conversation and said, I'm going to have staff meetings for everyone in Women's and Children's, and they're non-optional. You have to come. So, again, I don't do a lot of things that are non-optional. I don't like to do that a lot. But I felt these were so important that I felt I needed to restate our standards of behavior and how important those were. Remember tough conversations? You can't really have tough conversations with people if they don't even know what your expectations were. You got to start with what the expectations are. So we have this meeting, and this first one was a bunch of labor and delivery nurses. And it was in a fairly small room. There was about 30, 35, and it only went from maybe here to that third row back. It wasn't a big room. And I asked for the first part of the session, I wanted to talk about our standards of behavior. I literally have a flip chart there that I'm going through respect to your coworker, walking through our exact words of our standards of behavior. As I'm walking through this, Heather, the one that did this, was sitting about from, I'm standing here, maybe about to where you are right there, not very far. And she's sitting beside someone that she is talking to, having what we call a sidebar conversation. So as I'm talking, again, she's already told me she's going to outlive me as the boss. Okay? I remember that. I turned around and I said to her very respectfully, Heather, is there something you want to share with all of us? She said, nope, not a thing. I said, okay, just wanted to check. Turn back around, keep going through our next standards. We're flipping through, some different things, and all of a sudden she does it again. Having a sidebar with Carol and Kenny. This time it's even louder. It's getting to be a little bit more disruptive. So I turned around and said, you sure you don't have a joke, something you want to share with us, anything you'd like to tell us, Heather? Nope, not a thing. Nothing I want to tell you. Okay. Turn around one last time and start talking about respect again. And this time it's so loud. I mean, she's laughing. She's having, her own little party over here. Anybody know what's going on right here? What would you classify Heather as? She's a low performer, but she's also being a bully. Would you all agree with that? Because your low performers are going to also probably be your bullies. She's trying to very much intimidate me and the whole group. And we got this nonverbal thing going on back and forth. Who's going to do something here? Well, make no mistake. If you're the leader, you're supposed to lead. And if you're a leader and you're afraid of someone that reports to you, stand back, look in the mirror, and say, whoa, this is a problem. If you're afraid of someone that is in your department or intimidates you that much, we have a big problem. If they're intimidating you, the boss, what do you think they're doing to their peers? And let's take it a step further. What do you think they're doing to your patient and family? They are not helping your patient experience. Let me just tell you that. If they're doing that to you, the boss. So here's what I want to tell you. I had to put on my big girl panties that day and say, okay, I can't let this go. I can't let this go, can I? Because if I permitted that to go, I basically said it's fine. Everybody act like that. Go ahead. So I walked over to her and I said, Heather, And just like we're going to tell you in a minute, never say to a low performer, thank you. But I said, thank you for coming. And I think about it now. Thank you for coming to disrupt our meeting is what I probably should have said. But I said, thank you for being here today, but you're able to go ahead and clock out. I'll pay you for your time here, but you need to go ahead and clock out. She said, I'm not going anywhere. I said, no. I just, thank you for being here, and we're good. Go ahead. You can clock out. I'm not going anywhere. I had visions of calling security. And I'm going to tell you right now, I would have done it. There was a line in the sand. It was like my toddler. It was literally what it was. So I walked very closely to her. I made sure I had a presence. I looked at her, made eye contact, and said, Heather, let me be crystal clear. It is non-optional for you. You cannot stay. It is non-optional. You need to get your things and go clock out. Then it was just like here. You could have heard a pin drop. And I was prepared to call security. I was going to do it. But I think she decided, ooh, she must really mean it. She took her pen, she threw it up in the air, she made this big scene, and she storms over to the door, and it's just a little room, and she turns around and she goes, let me just tell you something. Nothing's going to change in our department. Nothing. Not a thing. She walks out, slams the door, talk about drama. Now, why does she not want anything to change in her department? She likes what she's got going on. And make no mistake, she is calling the shots in labor and delivery. Believe me. So I turned around, after she left, I thought, I don't even know these people. I don't know what's going to happen here. They're a bunch of labor nurses, and they can be a little tough. I didn't know what they were going to do. They all started going like this. They said, no one's called her out on her behavior in 10 years. Thank you so much. Now, I also know I got a bigger problem because the clinical manager of labor and delivery is in the room. Her boss is in the room. So I'm already going, I think this isn't going to be good. So later, we have a lovely meeting, had a great staff meeting. Everyone agrees they want to follow our standards of behavior. They want to help shift the culture. They absolutely want to be more respectful. About, 3 or 4 hours later, I get this phone call from the manager that was in the room. And she says, oh my gosh, I don't know what to do. Heather sent me an email, said she quits. And I said, happy birthday? I don't know. What do you want here? And she said, keywords, oh my gosh, I can't let her go. We'll be short-staffed. Do y'all know what I have now? I have a huge problem. Huge. I said, all right, I don't normally get like this. I don't even know you. But I'm going to be very direct, and I want to make sure that you understand what I'm telling you immediately. I said, you need to respond to her email and say, I accept your resignation effective immediately. Do you understand what I'm saying? And then I want you to sign your name. Who's in here from HR? Is that pretty clean? Wouldn't you say that's pretty clean? She followed what I asked her to do. What I said was non-optional. Crystal clear. The next morning, I get a call from Heather, and she said, I made a mistake. I got a little ticked off. I want my job back. And I said, have you already talked to Jane? She said, yes, she said I had to call you. I said, well, I'm pretty sure that you already put in writing that you quit. She said, yeah, well, I didn't mean it. I said, well, let me just be clear. I said, I don't have any vacancies right now. She said, what do you mean you don't have any vacancies? I'm still sitting in my spot. I said, I don't have any vacancies that you are going to be able to fill. Because the expectations that I'm going to have of you are 1,000% different. You're not going to be able to. You're going to be uncomfortable every single day. So then she said, well, can I at least come in and work the rest of my weekend? Let's see. So you can spew all over everybody all weekend? No, we're good. We're good, Heather. We're good. Bye-bye. Now, here's the end of the story. 6 months later, she called me again and said, I had no idea what I was doing. I had no idea how good I had it there. I've been at 2 other hospitals. I hate them both. Please, I've changed. Can I come back? Now, I'm all about people changing. I just really thought 6 months, we've moved a long way. And for me to go back and say, sure, come on back, I said, I'll tell you what. You call me in a couple years and we'll talk. But right now, I still don't have any vacancies. What also happened then was, and here's for the leaders in the room, particularly if you're a CNO, if you're a director, whatever, the higher up you get, the more difficult this becomes. I had to make some tough choices. That clinical manager in the room that day, we're looking for transformational leaders today. Transformation means you change things. Transformation doesn't mean that you do things the very same way and expect different results. Remember, transformation is this isn't going to work anymore. She had been their peers and had grown up there. She was kind of an icon. Was it going to be a hard decision? Absolutely. But my job, my number one job, is to take care of that patient laying there in the bed. I cannot have Heathers running around, low performers taking care of our patients. And at the end of the day, low performers are a leadership issue. Period. End of story. I didn't used to think that. Today I do. It's 100% the buck stops with me if I have Heathers running around. So essentially, I coached, did a lot of coaching, was very clear on my expectations. But she was not able to really adjust her leadership skill set or her leadership style. So I had to make a tough decision, and I changed leaders. Anybody think that was painful? The question I asked myself was, if I leave this person in this role, where will we be 1 year from now? We would have been in the exact same spot. And I got a boss telling me, I'm expecting some changes. Let's go. That's what we're looking for in healthcare today. These low performers, I'm telling you, I am at a point in my life that I have such low tolerance, no tolerance, none. A big part of what we do at Sarasota now is how we hire people. We are looking for in those peer interviews, and I'll hire a GN, graduate nurse all day long with the BSN. Sorry. Preferred. Because you know why? You guys go, pick me, pick me. I want to do this. I'm really excited. Let's do this. Let's learn. Where unfortunately, some of the nurses like me who have been in there way too long, we're very resistant to change. And we're not raising our hand going, pick me. We're raising our hand going, why? Why do we have to do that? Why? So today, if you want to change your culture and change what the patient experience looks like, you got to start with looking at every single person that's working in your department and what their performance is. Those low performers, here's the other really big question. Are you working harder at their success than they are? This was the question Quint asked me when I would call him and say, as I was coaching Jane, okay, now I've done this, now I've done that, blah, blah, blah. I call him all the time, and he finally said, you know, Pam, it sounds to me like you're working harder than she is. And, oh, by the way, don't you have a job that you're responsible and accountable for to get results? That was it. I was done. So ask yourself this one, too. Are you working harder than they are? I don't know why we do that. I think in healthcare we're used to pain. This was painful. We're used to rehab projects. I don't know why. We're used to giving people many, many chances, and I'm all about giving people chances. But at the end of the day, they have to want to change their behavior. They have to want to change and go where we're going in healthcare today. I've had so many nurses and leaders say to me today, I don't understand. For 25 years, I've got nothing but stellar evaluations here. What has changed? And this is what I say back. Healthcare. And the expectation of A, the patient, the consumer, and B, the expectation of our organization and me as your leader. That's the answer. It's so different today. So I want you all to ask yourself this. How quickly do you move someone out of your organization if they don't fit your culture or if they violate your behavior standards? And I want you to know that the word standard means you do it all the time. Standard isn't just, oh, I'd like to do this. A standard of care is a standard of care. A standard of behavior shouldn't be optional either. And how about this one? How long do you think leaders should be allowed to stay in their role? I can tell you in healthcare today, you might have leaders in their role for 20 years and not getting results. Today you can't do that because you can't hide. Today, everything's so transparent, you have to get results. So these two questions bring you back to really your values. So what do you all think about this? I want you to think of low performers as renters. They're just there clocking in. They're going to paint right over the possum. This one says, winner of the Not My Job Award, or paint right around the tree. They're not there to own what you got going on. Because renters do something, if you've ever rented a home or rented a car, I take the rental car back, I park in between two cars, because who cares? Get a couple dings. I don't park my car in between cars. I park on the end. It's always clean. We treat things differently if you own it. How about this? It's a really true picture, too. That's really kind of scary. This says, Nancy, I'm not sure that's what HIPAA had in mind. I love this. They asked if I wanted a message on the cake, and I said, please put nothing on it. This is not a critical thinker. I just want you all to know that, okay? And in nursing, we need critical thinkers, okay? Here's my personal favorite. Isn't that great? I love that. I think it's hilarious. I think I might try it. So as you're hiring people, as you're looking at who's working for you, healthcare gets really personal really quickly if you're the patient. This is my car. A few years ago, I got hit by a drunk driver. He was so drunk he didn't know he had hit me. My car, the back of it kind of looked like a Pac-Man had, taken out my trunk and my back seat. I walked away. I was fine. At least I was at the beginning. The end of the story is I started having very weird symptoms, and you know how we don't take care of ourselves as caregivers. Finally got to the point where I could only sleep in one little position, so I finally went into my, because my neck hurt so badly, went into my care provider. He said, I think we should probably get an MRI. Got an MRI, and it's bad when a neurosurgeon, Dr. Fine, calls me immediately and says, Pam, come over and see this MRI. I just want you to show something. I had this severe spinal cord compression. He actually said, I can't believe you're not having worse symptoms than you are. He said, this is very severe, and the reason I picked him as a neurosurgeon is he's extremely conservative. He would never do surgery unless you absolutely needed it. So he said, I think you need to have surgery within 30 days. And I said, what? Are you kidding me? He goes, no, it's at C4, 5, and 6. I said, whoa, wait a minute. What about traction or acupuncture, or can't I do something different here? I said, I'm not having surgery on my neck. I have 3 cadaver bones. I can now see dead people. Just kidding. And for those of you in the room that do this every day, I know that you do it every day. It's so routine. And he told me that. Pam, we do these. Peyton Manning. No. I said, I don't care. This is me. This is my neck. I had nightmares that I was going to come out of our hospital in a wheelchair. I mean, literally nightmares, like cold sweats. I ask Dr. Fine all the time, so what happens if you sneeze when you're right there? I mean, I was freaked. I've never been so anxious in all my life, to the point that I had picked all my caregivers, Dr. Nutter, the anesthesiologist. They kept giving me more Versed, all kinds of drugs. I was still wide awake. I was so anxious. When they rolled me into the OR, it got to the point, so any of you know anything about crew resource management and what can happen in an OR, I sat up on the stretcher and said, okay, I just want to make sure you guys are all getting along. Everybody getting along today, just in case? I don't want anybody to be having a fight here. Last thing I remember is Dr. Nutter putting the mask on my face. He goes, shut up. My point to you is there's not enough drugs sometimes to reduce our patients' anxiety. And had you thrown a Heather at me, had you thrown a low performer at me during this situation, maybe a nurse that kind of walks in with this kind of attitude and looks at you, rolls her eyes, I don't even know what I would have done. I don't even know. I probably would have had a total meltdown right there in front of the world because I handpicked everybody that was taking care of me. But not everyone gets to do that, right? And until we get to the point that you don't have to call ahead if you're the leader and somebody calls your family member and says, I'm going into your ER, that you don't have to call ahead and say, make sure she gets a good nurse. We're not there yet. And when you're the patient, everything changes, everything. I am such a believer in this today about low performers. So here's what happens when we have these conversations. I'm going to show you quickly what the conversations look like. We kind of start down here. I want you to see, we're going to have conversations that the high and middle performers are going to start moving in terms of their performance. They want to get better. What you see the low performer doing is nothing. They don't do anything. And what very often happens as leaders is we may be making some progress on whatever it is that you're working on until we get stuck at almost literally a wall. And the wall is we don't deal with those low performers. We let them suck the life out of us. We let those low performers or the bullies, whoever they are, hold us back and keep us from getting better. And then our results start to decline again. And this is where our staff say, I can't believe this, nothing changes, here we go again. It's because we're allowing those low performers, they're almost like an anchor. You know, you've got the boat revved up with the high and solid performers, and you got the low performers, it's like an anchor holding that boat back. And it's only 8 to 10% of them. So we have to somehow figure out how to get up over that wall and really move your performance. So this is what the conversations look like. And I already told you, 9 out of 10 of them, 90% are going to be positive. They're going to be positive conversations. You're re-recruiting the first two groups. You want to move your high performers first. I told you you're going to isolate them and pull them out first. This is what the conversation is going to look like. Your whole goal is to reward, recognize, and retain them. You want them to know how much you appreciate them. You want them to know specifically why they're so important. You might give them some real specific. These are the things you do that we wouldn't be a department without you. Tell them where the whole organization is going, how our goals fit into the whole organizations, and then lastly, look at this. We want to keep you. Is there anything that we should be doing better? What do I need to do for you as your leader? As your leader, what can I do to be a better leader? And if you work in a hospital or you get hired and this happens to you, stay there. Because we don't do this probably routinely enough. But if you're a high performer, how'd this conversation make you feel? Pretty good? Walk out with at least a little bit of a spring in your step after your leader did all this. All right, so then we're going to move on. The high performers have kind of trucked out and they know where they stand. They're with you. Now we're going to move those middle and solid performers. The goal, again, is to retain this individual. You definitely want to reassure them. By now they already know that people are having private conversations and they're a little anxious. So you immediately want to start with, I just want to let you know, this is going to be a great conversation. I want you to know that how much we value you. We want you here. You want to immediately calm down their anxiety, but give them one thing, just one thing that they could work on that would make them an even better performer, an even better employee. Just one. Then lastly, now that we've isolated those low performers, and like I said, they know this has been going on a unit, in a department. Everyone's come to the leader's office except for them. They're now coming in for a conversation because we've isolated them on the back end. I do want to say this because I've had so many people ask me this, so many people. We have learned over the past 15 years about a third of your low performers can be coached. I told you I absolutely believe we haven't really laid out expectations for people. And if you can really coach them, a third of them will do better. A third of them are in the wrong job, and a third of those, let me give you an example. We had what we call a health unit coordinator. She was very much an introvert, very much an introvert. We have her sitting in front of, in the middle of a bowl, if you will, in our labor and delivery area. Everybody's coming at her all day long. Introverts can't stand people coming at them all day long. By about an hour into it, she was already very rude and curt, and she was in the wrong job. That's also what leaders do. They look for, do I have you in the right spot? We moved her into another area, and she's done phenomenal. But the last third aren't going to succeed, and they need to be coached out. I believe that there are 33% that don't need to be in healthcare anymore. They just don't. And I, at one point said, in Seattle one time, I said, they need to be coached over to your competition. And someone called me out way back in the room in Seattle and said, excuse me, what if I end up at that hospital? I said, you're absolutely right. They need to just be coached out of healthcare. And I don't know all the reasons, but I do know that if they can't get that passion back or really want to be there. So for the low performer conversation should have a little bit of pain involved. We don't want to retain them. We don't want to recruit them. So this is what it looks like. We call it the desk. And again, this is all in the book. I'm going through it very high level. But remember that part about you describe the behavior you've seen. You literally walk through numerous things that you've seen happen. I mean, I could be so descriptive about what Heather did at the staff meeting. Thank goodness she quit before I had to do any of that. But talk about describing behavior and the impact. You evaluate the impact. You show or tell them exactly what has to change. And this is where we don't always follow through. They have to know what's going to happen if they don't change their behavior. This is where you get into really corrective action, and then you have to follow up. Follow up. I think in healthcare what we do, at least I've done very often, is I can do all of that, but then I might not put them on an action plan or set it up enough that I'm following up and making sure that I'm dealing with it. I know that things don't work well when in our areas, when I first, like I said, went to women's and children's, I found that we frequently had final warnings. Okay, I'm going to ask you all. Go back and look. What is that? That is saying, yeah, we don't really mean it. Just keep on doing the behavior. In healthcare, low performers are killing your patient experience. They're killing the people they work with. They're probably bullies, and they're making your environment unsafe. Why would we not walk through every bit of this? So what you end up with is improved performance across the board. Make no mistake, high performers do not want to work with low performers. High performers will leave your organization. I'm sure a lot of you do, I get emails every day being recruited all over the country, here, there, nurses, everybody. Healthcare is very competitive today. And if you're not dealing with performance, one of the best ways to keep a high performer is to deal with low performers so they don't have to keep putting out all the fires. So you're looking at moving it all across the board, and again, low performers are either up or out. What have you accomplished by doing high, solid, low performer conversations? You as a leader are role modeling your commitment to the standards of how we're going to behave. You're re-recruiting your high and middle performers. The employee, the low performer, knows that they have a very clear expectation. And if they don't change their behavior, they know what the consequences are. You know, healthcare, I think we might be the only business that hasn't done this. IBM, GE, there's a lot of businesses, corporations that have done this for decades. They've looked at their lower performing 10% of their employees, and every single year looked at how are we going to improve our performance. Part of how you improve it is to get rid of the lower performing employees. So great cultures looking at non-optional behaviors of excellence, and I'm talking about not only washing your hands shouldn't be non-optional, but also behaviors like Heather was exhibiting. You can't let that stuff go anymore, and we can no longer make those excuses. I am going to actually break here. What time do y'all have? About 5 till? 10 till? Okay, then let me do this. If I have 10 minutes, I'm going to briefly just hit this first part, and then we'll move into kind of the future of healthcare and a couple other things. Let me just hit very high level the future of nursing. And I want to start by saying the future of nursing is so bright, you all should be wearing sunglasses. I mean, it's unbelievable what's ahead of us. Some of the things that are changing healthcare, though, today, we've talked about a few of them. You see them up here. Transparency, to me, is probably the number one. That we're so transparent today in the expectations of the consumer, us as the patient. It's changing everything about healthcare, as well as whether or not we're going to get paid with CMS and our government. Technology is changing healthcare every day. Our electronic medical record, as you've already heard. Research, how we maybe learn something in school isn't nearly the same. Every day we have different, better drugs, shorter acting. Anybody remember Demerol? We don't even have it in our formulary anymore. Ick. Everything's completely changing. One of the biggest things is down here at the bottom. I don't know about you guys, but I used to say, okay, we've made that big change. Can we just stop now? That's not going to happen anymore. It's just continuous change. Over the last decade, this has been the most disruptive change. Anytime you change how you're being paid, anytime you change, you can always follow the money. Always follow the money. You know that it's the most disruptive thing that's happened to us. So instead of being paid today on how many procedures we do and how many MRIs we do, we're being paid today on things called outcomes and really what our results look like. It's fascinating how it's all changed. There's a whole lot of literature out there today, and what do we really get out of healthcare? Where's the value? Here's kind of the equation. The quality, which is your outcome, safety, and experience, over the payment. What did it cost to everybody that ended up paying for that experience? I know you've heard a lot about HCAHPS. You've heard a lot about what we call value-based purchasing. At the end of the day, the patient experience is always, in my opinion, going to stay right around a third of how we get paid. Our clinical outcomes are going to definitely remain there. Core measures, everything we're doing. We're responsible as nurses for so many of those, nursing-sensitive indicators, whether it's CAUTIs, CLABSIs, et cetera. And over here, 30%, at least, if not, you're going to see that go up, 20% is going to be based on that efficiency. We have so much waste to cut out of healthcare. I love this definition. I think it's actually better. No outcome, no income. You're not going to get paid if you don't have great outcomes. It's just that's how it's going to be. What is healthcare reform really about? In a nutshell, it is we cannot sustain the cost that we have here in the United States. We're the most expensive country, and our outcomes are certainly not the best. If you look at us, we're way down, like maybe number 12 in terms of our outcomes. We still have things like prematurity. We still have all kinds of infections, accidents, all these things that are really driving this cost. So this is where nurses come into over here. We're looking at keeping our population healthier. You just heard earlier about how we want to have access to our own data, our own medical record. We have to be so much more in charge of our own health. Hence, I got to get up earlier and walk in the morning, right? But if we can stay healthier, because we know we spend 50% of our high costs go to about 5% of our population, and that we spend so much money on those last few weeks of life in an ICU, et cetera, as well as on those very chronic conditions like morbidly obese, hypertension, diabetes, et cetera. So today, all of this is changing so rapidly. We really have to be in that position to be able to kind of, I'll just say, see the future and keep moving, if you will, and staying energized. Here's something I want you to remember. This is what we call, again, I don't like that word execution, but down there on the bottom, the only way we're going to really be accountable, highly reliable organizations is down there in the bottom. We have to be so consistent every single shift, every single day, 24/7, 365 days a year. We need to be reliable to our patients, to those that entrust us to take care of them. Quint will tell you this all day long, and I completely believe it. You have to focus on your culture. You have to focus on engagement, what you're doing in your areas to take care of people, that they don't want to leave you, that you're keeping only the high and solid performers. I'm going to end right there and come back when we get back with what I like to refer to as the decade of the nurse and how the future of nursing is being driven so much by healthcare reform. So how long is this break? Where's Peggy? All right. Thank you all for coming back. A couple of things that I want to make sure I connect the dots. I've had different comments at breaks, and one of them was around the EMR in the patient's room. I wanted to make sure that I circled back around to that. I hope you heard me say we have to really describe to our patients what we're doing in there. You can't just be on the computer and not connecting the dots for our patients. I know there's probably different ideas today around technology. You saw that as one of the major drivers. I will say, though, that I think there are some positives. My mother had a heart attack in December and had 2 stents put in. I'm going to tell you about that. But in her room, while I was in her room, Kim, my very favorite cardiac nurse, I said, I want to see her blockages. Can you pull them up? She pulled them up right there. Of course, she said to my mother, is it okay if she sees your electronic medical record? My mom said, yeah. So she pulled it up right there. So that was a great thing. I didn't have to wait 21 days to look at my electronic medical record. Things, though, for example, in Sarasota, we have something called Volt, and it is literally an iPhone that we communicate with. And there are so many positives to it because it helps with efficiency. You get a text that such and such patient needs you in the next room for pain meds. So you don't have somebody calling in the room and you got all this stuff going on. Am I going to tell you that we always have to connect the dots for the patient? Of course, because they have to know we're not calling our daughter or our son at home. Does it make us more efficient? Absolutely. The patients love it because we're quicker and it really reduces the noise on the unit. So technology always has to make sense. You always have to use it that it makes sense for the patient and family. A couple of other things I wanted to make sure that I connected the dots that I didn't do earlier. I personally believe before we leave tough conversations and high, solid, low, I personally believe we're just on the beginning of what we're looking at in healthcare around incivility. Call it lateral violence, call it bullying, call it whatever you want. But we know that we have incivility in the workplace today. There's studies out there. There's one book that I haven't read it yet, but it's called The Real Healthcare Reform, or Civility in the Workplace. Some of the studies show that some of the most incivil employees are the leaders. And we also have some reports that show that we've got some very low-performing leaders. And what do you do if you have a low-performing leader? I've had low-performing leaders. And what I will tell you is there are times when you get to the point of I'm not working for that person. I'm working for the organization. And I have kind of kept that mantra. I'm working for the patient, the customer, the family, et cetera, and for the employees that report to me. I'm not going to tell you it's easy, but I am telling you that I feel like we're very much in a cultural shift right now. We're in transformation for healthcare. A couple of other things. If you're a leader, it's so important today to have self-awareness. If you read anything about emotional intelligence, it's one of my favorite topics. Read about emotional intelligence and how you can't just be book smart. If you have that emotional intelligence, the number one thing is self-awareness. I've had leaders tell me, I don't see myself as being a bully, and they probably don't. But that doesn't mean that other people don't see you that way. And again, if you're a leader, you have to have self-awareness. You have to be open to feedback of what your staff, what your peers are telling you. The last thing that I just want to make a point on, and it's only because I was just in Kansas, talk about being in the Midwest here lately. I was in a very small town in Kansas, and they're going through a big leadership change. Their CEO is retiring after 30 years. And she was talking to me about how on the side, not in front of anybody, but she was talking about one of the biggest struggles they've had as a small rural hospital is they live in such a small town, everybody knows each other, and that it's hard to sometimes, coach people out of the organization. I understand that, I absolutely do. I get it. But I want to, again, kind of make this point. If you do not really deal with performance, particularly leadership performance, you are allowing one person's life to affect so many others. In healthcare today, what we do affects entire communities. The ripple effect of a low performer, and especially a low-performing leader, I personally can't put my head on the pillow at night anymore and feel that I can do that. It's not about one person. And maybe it is about getting them in a job that's more suited to them. But when you're in a leader, it's all about getting results today in healthcare. You have to. It's not about hurting someone's feelings. It's about the greater good. I hope you all will go with me on that, because that's what we do in healthcare. So let's move to the decade of the nurse. And of course, I have saved way too much here at the end. So I'm going to go through quite a bit of this fairly quickly. I like to spend a lot of time on change models. I'm not going to have time to do all of those examples today, but just kind of give you some very high level. I know you have access to these slides. I hope that perhaps I'll hit something that you might want to go back later and say, what was that again? And go back and maybe pull up the slide or the research, etc. So I asked myself, I became a nurse in 1978. So why nursing? What does a nurse do? I want you to kind of think about this for a minute. Is being a nurse just a job for you, a profession, a career? How did you choose nursing? This is me. I went to an ADN program in Heston, Kansas, because it was one of our Mennonite schools. My name was Hirschberger, if you've ever met a Hirschberger. Why? Because my cousin Carol, I didn't have a sister, she was a nurse. I really picked a scientific way of going there. And also she came home with her husband from Heston College, Rod, who was probably the most handsome man I'd ever seen in my life. So I decided I wanted to go there. So as you can see, I really picked, scientific ways of getting this done. So I started with an ADN, BSN, MSN, and then as you heard, I really got re-engaged or re-inspired and went back and got my doctorate. Now, before you get real excited of, whoa, I don't think I could ever do that, I said the very same thing. The reason I went back to school was, A, I hadn't been there for 25 years, and B, my twin daughters were leaving, and literally we're going to be empty nesters. So I said to my husband, so what are we going to do here? I mean, I'm going to be bored out of my mind with, having 3 kids. So I went to the very same school they were at, Florida State University. It was hilarious, too, because I got to know all the hangouts, all the bars. Now, Tallahassee is 5 hours from our home, so I wasn't there that often. Most of mine was online. But I definitely kept an eye on them, and I tell them all the time I graduated before they did with a much higher GPA. So this is also the other thing. They would say to me, I have no idea how you're doing this. You have 2 jobs, you're in school, you have to deal with Dad. I mean, and I've told them that I think it's so important that our children know there's so many opportunities out there today, and that you're constantly pushing yourself and learning. We have so much to be thankful for in nursing, and just a couple of things. We're the largest single component of hospital staff and primary providers, and on the nation's long-term care as well. You can see over 3.1 million registered nurses, and if we all, I believe this in my heart, ever got united with one united voice, we would be a force to reckon with, wouldn't we? But we've really not gotten to that point. As we look at affordable care, the Affordable Care Act, we also know that we're going to have many more insured patients. And this is what we're going to be faced with in terms of, yes, we're kind of coming into another nursing care a shortage. And as you are looking at BSNs in your areas, just like we are, we have literally sat down with our colleges and really had to sit down and have the employer, the college, and the community helping us come together saying, how are we going to possibly work through the supply and demand? And I think you all know, I'm sure it's extremely competitive here to get into nursing school. Heck, when I became a nurse, I just called and said, I'm coming. They said, sure, come on, right? Do y'all remember? It's not that way today, right? Not at all. Here's our reality, and I think I already told you this. We spend more on healthcare than anybody else, but out of 17 high-income countries, we have the highest prevalence of look at all these great things. It puts us at the bottom of the list for life expectancy. I didn't know that. It's pretty amazing. The World Health Organization, National Institutes of Health tell us that. So the Institute of Medicine, I'm sure that you saw the future of nursing. This huge report came out about what's kind of next, where we need to go. These are the key messages. The number one is nurses should practice to the full extent of their education and training. I am so lucky, not. I live in the state of Florida, and we are the last state in the country. Every other state in the country has gone ahead with ARNPs can practice with even prescribing narcotics. We're not able to do that. In Florida, we can't even prescribe cold medicine if it has anything in there that's a little bit of a narcotic. We have taken it to the legislature every year for the past probably 10, but it's one of those things that I think we might finally be making a little bit of traction. Should get higher levels of education and training, should be full partners with physicians and other healthcare professionals, and that we do really have to have more effective workforce planning. We're finally, ladies and gentlemen, sitting at the table, as far as I'm concerned, in where healthcare is going. That Institute of Medicine report, again, these are some of the things, a few other things that they put out there. And if you're wondering where the whole thing of more BSNs came from, it's not from Magnet. It's from the Institute of Medicine saying that in what the studies have shown, I don't know if you've seen some from Dr. Linda Aiken. She has done literally from University of Pennsylvania. She's the one that's done the most. Longitudinal studies now to show that the higher BSNs in a hospital, particularly in acute care, the lower your mortality and your morbidity goes down. In other words, and I'm not saying anything about ADNs, diplomas, anything. I was an ADN. I think all they're trying to show is, and the research, the data shows it today, that it does correlate. So IOM put out this report and kind of gave a push, if you will, to have 80% of BSNs by 2020. I don't know about you, but our organization, we're nowhere near that. We started at 45%. I think right now we're at about 55. But we're pushing, we're still striving to do that. Oh, of course, that infrastructure as well. So the 80% by 2020 is based on what's in the public interest. There, I just told you this, 10% increase shows a 5% decline in mortality. I think the biggest thing, too, that we've come away with is if, and again, there's nothing wrong with ADN programs, nothing. But what we've shown over the years is if you have so many different levels of where you can enter, we're not going to ever have enough faculty to get to the supply that we really need. So these are the things that are really being pushed out there all around the country. What I do know for sure is that healthcare needs us today. If you know anything about value-based purchasing, it's just like I showed you earlier, no outcome, no income. We're not going to get paid for a patient that comes in 30 days later. If we have sentinel events, which is the never event, they fell in your hospital and broke a hip. If they got an infection, all those hospital-acquired never events, we're not going to be paid for those. We also get to the point with quality targets. I'll give you an example. I know this is happening. Last June, Sarasota Memorial, and we pride ourselves. We've been Magnet recognized 3 times in a row. We really think we're awesome. We wrote a check back to CMS for, I believe, $1.7, $1.8 million because our CAUTI rate was higher than expected. That hurts. $1.7 million. What we did with that is took it back to all of our unit practice councils, all of our collaborative leadership, and said, whoa, our nurses were mortified. So now, just like you, we're doing all of those things like, wait a minute, why do we need a catheter in this patient? What are we putting this in for? Getting it out on post-op day 1, all those things that all of you are doing. But I want you to know is it's here, it's now, it's happening. Hospitals are absolutely being faced with it. It's not coming, it's here. And every year it's going to get more difficult. There's no question that we have preferential employment for BSNs. And what we're trying to tell our staff at Sarasota is this is going to be happening all around the country. Now, if you're going to retire in 5 years, of course, but if you're going to be in a career for a while, this is definitely the movement. This is definitely where healthcare is going in nursing. And for those of you that have been in nursing as long as I have, how long have we had the conversation? What should be the entry level? Should it be a bachelor's degree? Just so you all know, I don't know if you know this, but physical therapists today, you have to have a doctorate. I mean, every healthcare profession is moving, again, towards more and more education. I told you about a few of those never events. These are some of the financial impacts, and this came from CMS is where I got these ranges. But look at this right here, an infection after a cabbage, $299,000. Let's see, the deep vein thrombosis, pulmonary embolus, about almost $51,000. You can see why CMS, the government, all of our payers are saying, well, I'm not going to pay for that if you guys caused it. Not that we're anywhere like a car, but if you took your car in for them to fix something and when it came back out you had something else that was wrong with it, you don't want to pay for that. You see where I'm going with all this? The public is literally saying, we're done. We're done with this. We're not going to pay for it. So how are we going to get there in terms of healthcare reform? One of the biggest things we're going to have to do is really kind of change where we get our resources upside down. We spend so much money on acute care right now. What we're looking at is now spending money on prevention and primary care to keep people healthy. Again, you saw that really have a healthier population. We talk about population health today. We talk about covered lives, all the things that are out there, accountable care organizations, all the buzzwords today. And it really comes down to this, how do we keep people healthier? This isn't going to happen overnight. It's not going to magically happen. But you can start to really see it. It is happening across the nation. The other thing, and we talked about this at lunch, there is such a variation in outcomes across the nation, whether it's mortality rates, patient sat, all kinds of variation in staffing and education and the work environment. I was telling Regina at lunch that I didn't want to go where she was getting care because she was telling us about a 1 to 20 patient-nurse staff ratio in an acute care facility. So you'll see variations all around the country. And I don't even know where it was. All I'm telling you is we're in the Midwest. We're in pretty good shape. But I would ask you to go out and Google this. If you're ever going to move, go check out the healthcare first. And I'm very serious about that. What we know about nursing leadership today is we have to have so many different competencies. Oh my word, 15, 20 years ago we would never even have been talking about this. So you look at AONE, American Organization of Nurse Execs, and this is what they talk about in terms of competencies, professionalism, which there's all kinds of things under there, communication and relationship management, knowledge of the healthcare environment. If you don't know what's happening in the external environment today, there's no way you're going to be able to keep up with it, which is why I started with something as simple as tough conversations, and I want to keep correlating how important they come back to the changes in healthcare today. The one that you definitely wouldn't have seen 15, 20 years ago is business skills and principles. As nurses today, nurse leaders, we have to be almost financial wizards, if you will. We certainly need to at least know the basics. This is from Linda Aiken, Dr. Aiken at University of Pennsylvania. And what she talks about is making sure that we have really invested in that patient to RN ratios. She talks a lot about the nurse work environment and why nurses want to stay, that you want to keep them engaged and they don't want to work somewhere else, and that there's no question, even with, she's done research around a higher percentage of certifications. Yes, they help, but it's not going to help even more if you don't have that educational level. The educational level is what leads to lower mortality. This is what she also says that is the most important to the outcomes, that better educated nurse workforce, improved nurse staffing. Oh, I love this. Improved nurse staffing in hospitals with poor work environments is not a good investment unless you're improving the work environment. It's so critical that you have a good working environment where nurses want to work. I don't know about you, but I've seen this over and over. We get into sometimes bidding wars where the hospital across the street will pay sign-on bonuses and they'll pay you $5 more an hour. We refuse to get involved in that because what we've found is if you build your culture and you make your culture right, that's where you can pay people a little bit more and they'll go over there, but where they want to stay is where the culture is really the staffing ratios, that we don't have a lot of incivility, etc. Promoting good work environments is a relatively low cost to improve patient outcomes. So true. And magnet intervention is certainly, the magnet journey is a good intervention. All right, so here's another thing. Ding, 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 highlight this. Good work environments are a direct reflection of good leadership. At the end of the day, if you have a lot of turnover, if you have a lot of things going on in a department, you always have to come back and look at the leadership. All right, now I'm going to move a little bit into novice to least engaged, and we're going to move into change here shortly. Many of you have heard about this, I'm sure. Did you all study this, Benner, in school? Patricia Benner? I don't know if, well, maybe you're not there yet, but we've talked about novice to expert for many, many years. So I'm going to go through this just very quickly and what a novice nurse looks like. The novice nurse is over here. No experience and just really needs rules. Rules have to be applied universally, and they just have no life experience in the world of nursing. I like this at the bottom. Just tell me what to do and I'll do it. I don't know about any of you, but when I was a brand new GN, it's that whole thing of you have no idea what even to ask. I mean, you got through school, but now you're out there, and I remember going, are you sure I'm not still a student? You mean I have to, like, these are my patients? Like, I'm assigned to them? Are you kidding me? So it is scary. It's really, really scary as that novice nurse. Then you walk into an advanced beginner, and they start having enough experience to kind of look at some guiding principles. Their knowledge is starting to be based on experience. Then you get to, we don't really know for sure, competency is probably more around 2 to 3 years. And certainly it depends. A lot of things depend. But you look at things around contingencies of different things that they have to prioritize. They might have mastery, but you've seen this before. They might not have the speed yet. There's still their time management, etc. And I'm basically, this could be in an acute care setting. It could really be just about anywhere. Then you get to proficient, where they see the patient kind of as a whole. I don't know about you, but I remember that going, okay, the cardiac system, you know, you kind of cut things up in little systems, where now you're starting to really see the patient as a whole and kind of modify things based on the situation. When you get to an expert level in nursing, it becomes very, very intuitive. It's very fluid and flexible. You don't really need a lot of rules to really know what's about to happen. That's where you get into literally that gut feeling of this patient's going to crash. Now, I want to make one point that I absolutely learned in school just recently studying all of this is sometimes Dr. James White made this point so well, and I'll never forget as long as I live. He said, not all nurses ever get to proficient or expert. Definitely not all nurses are expert. And what he said was, where you get to proficient and expert is these are the nurses, I like to think of these as high performers. They're over here, and if they don't know the answer to something, they're going to go look it up. They're going to go make sure they know what's going on with their patient. They're not going to go, oh, I'm not quite sure. They're going to go look it up because they want to be that expert. They're taking care of someone's life, and they want to make sure they know exactly what's going on. And he's right. I think he's absolutely right. You don't always get to that expert level. So that novice behavior, I think that whole thing of just tell me what to do and I'll do it, I want us to all remember that if you have novice nurses, to really start with looking at your programs, your GN programs, your residency. You saw that Dr. Aiken said that's a great big recommendation, and from IOM, that we have residency programs. When I first got out of nursing school, many of you probably felt this way. They kind of threw us into a unit and you kind of sunk or swim. You had to really develop relationships with people to help you out all the time. But what do we do with novice nurses today? The advanced beginner, kind of where do you know they're moving into, having a little more confidence in themselves, and what do you do at this stage? I think it becomes really important that you've set them up with somebody at the novice level, that they're phenomenal preceptors, and that you have literally a mentor for them. And I would ask all of us as leaders to go back and look at how we educate our preceptors and our mentor. How do you really look at your preceptor program? Have you done formal education? And have you looked at it lately? What I found was we had some preceptors that had been doing it for 20 years, and they really didn't want to do it. We really hadn't put in some kind of infrastructure or data to really see how things were progressing. So go back, kind of look at that with a fresh pair of eyes, and let's re-recruit these brand new novice advanced beginner nurses. Then we get to, actually, this I think sometimes the advanced beginner is sometimes one of those that you're still kind of running around with your hair on fire. They still kind of have that, deer in the headlight look, and they're still a little bit, like they look at you like, help me, and you can see it. But we have to be observant for that. We got to look for that. We have to have self-awareness and say, what can I do to help you right now? How can I help? And as new nurses, we all remember when somebody said that to us. It was like, oh, thank you. So competent, what are some behaviors around competency? Again, I think they would be able to explain all the anatomy and physiology and walk through everything of what they would do, but they may not be at that point of feeling like they're mastering it or that speed and flexibility. Part of competency, too, is all of a sudden you got a curveball thrown at them, and they're probably not ready to be in charge, that type of thing, because you've got so many things coming at you in healthcare today. They're not ready for all of that. But how do you move them from proficient to expert? And what are actions that we're not going to frustrate our proficient and experts? How do you constantly be kind of assessing your nursing staff and the nurses that are on your unit, in your department, and continually move their performance, continually make them better? I think for me, a big part of looking at our novice to expert is building their confidence. If you've ever made a medication error, if you've ever done anything in healthcare, and I think probably all of us have, I can still tell you about a heparin drip error that I made today. There was no real untoward outcome, but I can tell you for about maybe 5-6 days I wasn't sure I should be a nurse. And how we all go through those things. And be on the lookout for that. Talk about it. Let your staff really know that you're aware. We use a lot of the concepts of team steps, and we use something called a debriefing. We use debriefs all the time. Don't ever forget how important that is in terms of taking our nurses from novice to expert. The other thing that I'd love to have discussion about, we don't have time really to discuss it today, though, is the whole idea of how you take, let me just make sure I know where I'm going here. Okay, I got it. How we take that whole side of critical thinking. Remember, put nothing on it, on that cake. How do you get to critical thinking? I think a big part of it is, again, we don't rescue our nurses all the time. We're constantly not really challenging them, but I like to ask the question, well, tell me what you would do. Tell me what you would do first. And 9 times out of 10, they have the exact right answer. Sometimes it's just something a little bit that you can tweak that would make it even a little bit better. But constantly building their critical thinking skills. Okay, now I'm going to move a little bit we're going into burnout a bit. But I want to start with another Gallup poll that talked about honesty and ethical standards and who's rated the highest. Maybe most of you know this, but nurses are rated year after year after year as the highest. The public trusts us. They think we're honest, that we have high ethical standards. And while I have this up here, I want to just throw one other thing out around ethics that I think is so important as nurses today. And it's so important we sometimes can get away from it. One of the basics of nursing is our code of ethics, the basic tenets of nursing. We have a lot, and I don't know if you all do, but we have a lot of moms in our NICU that have abused drugs. It's not cocaine anymore, but the baby's going through neonatal abstinence syndrome. And we have gone through this over the years, but really that whole thing of we bring our own values into the workplace and how we absolutely can't do that. We all have to challenge each other on that. That we can't be making judgments about the patient, be talking about the family, all of those things that when you're a nurse, you sign up, you have literally almost an oath of I will meet you where you are today. I have no idea what happened to you in your life to get you here today, but I'm here right now. I'm not going to judge. I'm going to take very good care of you. That's what society expects from us. Is it hard sometimes? Of course. Of course, it's hard to say, this mom abused her body and now her baby is addicted. Absolutely. But I have no idea what brought her here. No idea. I mean, there could have been abuse. There could have been all kinds of things that have brought that family there. So for over a decade, we've been the most trusted, and it's very, very well placed. I love this. Karen Daly, president of ANA. It reflects an appreciation for the many ways that we provide expert care, and if there's one thing we are as nurses, we're advocates for our patient, aren't we? We are advocates. We're going to do what it takes to take care of our patient. So we're also the least engaged. We're rated the number 2 least happy profession, right behind security guards. So this is just from one data point. But look what we're unhappy about: compensation, growth, opportunities, and workplace culture. We have more issues with the culture, the people they work with, and the people they work for. So again, I'm going to go back to look at everything on here. It's all a leadership issue. Every single one of those. The culture, the environment, the people they work with. Are you not taking care of low performers? And maybe you're even a bullying leader. You're an incivil leader. I don't know. I really don't. A good work environment, this is what the literature's showing today, so let's look at this. This is from, again, it's called the Practice Environment Scale. Enough nurses to provide care of reasonable quality. The nurses would like to be involved in decision making. They would like leadership to be responsive in solving problems, at least around patient care. Wouldn't you all agree with that? They'd like communication and collaboration with the physicians. Again, a leadership issue. And if there are issues with physician relationships, it comes back to you can't permit that stuff. Investment in qualified nurse workforce and an institutional commitment to quality and safety. All of those things make up a very good work environment. Where did Magnet come from? Magnet was based on about 25 years now of research. This is where we started with innovation and a research study. We know that magnets have better staffing. They're 13% less likely to have high levels of burnout, and 18% are less likely to be dissatisfied. I would tell you that those numbers correlate very closely to how much emphasis magnet organizations put on the work environment and shared decision making, making sure that nurses are in charge of their own practice. So now I'm going to move into leading through change. And kind of, actually, we're doing okay here. Look at that. Well, almost. Let me start with, people like to be settled. And I think this is, again, a basic tenet of change today. We get up in the morning and we do things over and over. We kind of have our routine. How many of you get up in the morning and you make all these decisions you're not even thinking about? You brush your teeth, put your contacts in if you wear contacts, you get in your car, you drive to work, and heck, I don't know about you, but sometimes I get to work, I pull in, and I literally go, okay, I have no idea how I got here. Anybody ever feel that way? Because we just do things routinely. We make so many decisions just like that. So then you get into, all of a sudden, we're throwing so many things to really mess with your routine and the things that, as a leader, perhaps, or even a brand new nurse, the fact that you got into nursing school is amazing. And I know that from many, many different formats today. So you all should feel very good that you've even gotten in there. And is this your last year? So you're this close, right? 5 weeks! Woohoo! So unless something really bad happens, right? But of course you still have to take your, I get it. I get that NCLEX and all of that. Oh! Anyway, so you do all these things, you've been a leader, you've been a nurse, and you do things routinely, and now we're constantly throwing stuff at you to tell you, you got to change. You got to change. So I'm going to do something that's really hokey. You all can say it's hokey, but I do want you to know that it's non-optional, okay? So I want you to do something really goofy for me. I want you to just fold your hands at your table. Some of you have done this with me before. And what you did when you folded your hands was very automatic. You didn't have to think about it, but you got one thumb on top, right? So now I want you to change and put the other thumb on top. It feels kind of weird, but you can do it, right? So now I want you to do one other thing for me. I want you to fold your arms. Fold your arms. You didn't have to think about which arm do I put up first. Your brain just got you there, right? Just automatic. Now I want you to switch your arms. Put them the other way. I don't have a neurologist in here, or our synapses, right brain, left brain, and all of that, but it feels uncomfortable, doesn't it? But did you do it? You did it, but it feels uncomfortable. So as we talk about change, I want you to remember, I can do this, but it feels so uncomfortable, seems so foreign. Having a tough conversation is so uncomfortable. Telling a low performer, really outlining what they need to do to change and following up, and maybe even coaching them out of your organization is very uncomfortable. But you can do it. I absolutely know. We're nurses. I've decided we can do anything. We're nurses. So as we talk about change, I want you to remember change isn't really always bad, and it's not something that we should always fear. For example, who doesn't want to get married and be happily ever after living in love? And then we get married and then we make this conscious choice to have a baby. I mean, it blows my mind to think about it. Talk about the biggest change you'll ever experience in your life, right? Not only financially, but, I mean, they don't leave. They're there. I mean, they never leave, right? But we want it. We prepare for it. We're so happy. We have children. The biggest change you'll ever have. So it doesn't really mean that it's always bad. Then they grow older. They graduate from college. And like I said, what do you mean I'm not a student? I'm a real person. I got to have a job. Ugh. So many things happen. It's not always bad stuff. What I want you to remember, though, and many of you have seen this, and this comes actually from Maslow, his hierarchy, but I want you to know that there are competencies of how we feel in terms of individual competencies and change. We start out, you can go back to Benner and kind of that novice. We're unconsciously unskilled. We're a brand new nurse. We don't even know what we don't know, right? We have no idea. We're walking around unconsciously incompetent. We have no idea what we don't know. Then we move to a little bit of that competency and you're a little bit more proficient of your consciously, okay, now I know the questions to ask. At least I know where to go and how to kind of do this. I have a brand new pediatric leader, Desiree Berry, and you can literally see her going through these stages. When she first signed up to be the leader, she's like, yes, I really want to do this. And as the weeks have gone by and, there's more things to do, she's like, oh, this wasn't exactly it's a little tougher than I thought. And as much as you try, you mentor, as much as you get into resources, you still have to go through all of this. Then you get to a point of being consciously skilled. And then almost that thing of, this is so automatic. I come in the morning, I do this, I got everything down pat, I am unconsciously skilled. I can do this sleeping and, walking through. That's where we very often get as leaders. And what we're asking you to do, because you've already got some kind of success to have become a leader, what we're asking you to do is to go back to being consciously unskilled when we're asking you to do new things, new skills. I would love to spend an inordinate amount of time around change models. I am fascinated by change. Although I did confess at lunch today that I have had a new computer, a new laptop now. I brought my antique, but I have had a new computer laptop for about 6 months and I still haven't fully converted over. It's not that I don't want my new computer, it's just that I got to delete so many, you know how much time that's going to take? For the most part, I love change. For the most part for me, I'm an old ER nurse. I feel like I triage things every hour, gives you these life skills. It would kill me to not have change because I want to constantly be learning. And if you look at change in that way, at the very cellular level, if you're not changing, you're dying, literally. So I've looked at a lot of different models around change. One of them is John Kotter. And if any of you have read anything around Kotter, he's been around for a really long time. He's worked with international businesses. I mean, he's almost what you would call an expert on change. There's a lot of others out there, though, today. My point with, and I'm going to just walk through very briefly what kind of this looks like, one of my points is go out and look at change models because I do think they help you walk through whatever it is you have to be doing, whatever you have to change. And I'll give you a couple examples. There's also a book out there today called Switch. It's written by Heath and Heath. Phenomenal book on change. Couldn't put it down in the airport I bought it. Anyway, this is what Kotter says. And again, I'm going to kind of use, remember I told you I can only remember things in threes. That's all I can remember. So he has these 8 steps, so I've kind of clumped them. First, he talks about you have to create a climate for change. You have to kind of be throwing things out there and getting people ready. You can't just, or to make it stick, you can't just walk out and say, like I used to do, all right, today we're going to start doing this because I said so. That's kind of how I used to lead. It doesn't work anymore today. It doesn't work with the brand new nurses coming out, the kids my age coming out into the workforce. It just doesn't work. You have to create that climate for what are we doing here? What's the why? Then you want to make sure you get out of the way and you engage people and enable them to make the changes. And lastly, as leaders, we have to figure out how to make sure after we've implemented them that we're sustaining the changes. So let me give you a couple examples on each one. The first one is increase the sense of urgency. Remember, I told you this a little while ago. Don't forget this. If you've got that gut feeling that this is a low performer, I heard him complain about free food. Darn it. I know they're a low performer. And you've got this feeling in your gut that you need to do something. A leader then will start paying attention and create a sense of urgency. I can't walk away from it. I got to do something with that. Then, so let me think up another with a team. You're not going to get a team to fire somebody, huh? So let me think of something else. A few years ago, when I told you we first started really looking at women's and children's and our cultures, part of our cultures were that labor and delivery, it stopped right here. We're done. And when you took us up to the mother-baby unit, I told you that was like an island, and never did anyone speak. And our patients would literally tell us that. I don't understand what's going on here. So we had to look at how are we going to streamline and make this a much more a patient experience that our patients are going to love. First of all, we weren't working well together as a team. There were so many things to look at. So we sat down, and I knew we had to deal with this. From one example, the reason I knew we had to is there were some days that we would have 15 deliveries, and the next day we'd have 2. So our resources, now where'd those 15 deliveries go? They went up to mother-baby. So now all of a sudden up there, those patients, it's all hands on deck. But I got nothing going on down here in labor. But you think that we had any labor nurse that wanted to go up to mother-baby? How many of you think that when I threw out the word, perhaps we should cross-train? Do you think anyone went, oh, that's a great idea? Not really, not so much. So we built literally a team, a small group, and said, and they were high performers. They were people that were listened to. They were leaders on their units in mother, baby, and labor. And we really started saying, what is it we want to get to? We broke it down into get the vision right. We want to have 8 people cross-trained from labor to mother, baby in the next year. We'd like to ask for volunteers first. And we really started breaking down what the vision actually looked like. We started communicating, really having it out there everywhere. We were talking about it. We want this to really be something everyone knows that we're looking at doing. This is where we're going. So we enabled action. We had a few volunteers. They weren't voluntold. They were volunteers. They stepped up. Johanna Krempel was one of them. She is one of the foremost brilliant labor nurses we have. She was also one that was on the team, and she said, I'll do it. I'll cross-train to mother-baby. Let me see how this goes. And people trust Johanna. So Johanna went up there. We did the cross-training. We made sure that we got out of their way and gave them the training. Because if you're going to do something like this, you're not going to get the change if you don't step out of the way and get what needs to be done. You have to commit to that, to give them the resources. She went up there. She actually said, this is pretty amazing. I got to see the mom that I delivered, and now I get to have kind of a continuity that I see her up here in mother-baby. And the patients loved it, absolutely loved it. So as we started creating some little short-term wins, I asked literally Johanna to be an infomercial. She was a walking infomercial, talking it up, talking about it, and how it really wasn't that bad, and as a matter of fact, I kind of liked it. So then we got a few more people to do it, a few more. We're now where you get to don't let up and make it stick. We're now 4 years into this, and we have a huge core group that will float between mother, baby, and labor and delivery. You talk about being more efficient with our resources. You talk about our patients loving it. And really what has also happened is it's broken down all of those terrible silos of, I'm a labor nurse, I don't talk to you, the mother-baby nurse. What it's also done is increase our mother-baby, their level of performance. Now we have, for example, if we have to run MAG on a patient post-delivery, the labor nurse will go up to mother-baby and help them get it started, but they now have the competency and the confidence to be proficient at given MAG. So there's so many benefits to this huge change that we did. It was huge. I'm talking huge. It's transformational. Now what I also want to know is let you know is an antidote to this is we actually we're talking about it the other day. We went through high, solid, low performer conversations as we were doing all of this. And I would tell you in mother baby, I think we had roughly a 40% turnover. It was extremely high because of the resistance we met to change, really those dug-in donkeys, low performers, where our nurses would tell you today, I could have Noe Butler walk in and say, it's a whole nother place. I had no idea that it was quite that bad. And what the word she told me was, I had no idea we were quite that toxic. So what I know is, change can happen, but if you really follow a process as well, it helps you stay on track and kind of really remember what you need to do next. And I'm giving you such high level, very, very high level, but if you have any project or anything that you have to implement, something that is small as, to me, cross-training was not a big deal, but it was a really big deal to our staff. So even if you think it's not a big deal, to go back and really look at a model such as Cotter's. I also love to read, this is from Everett Rogers, and he talks about adoption of change, kind of diffusion of innovation and categories, that bell curve. You could kind of go back to this bell curve with high, solid, low. But what he talks about is that in a bell curve of when you're changing, there's really only about 2.5% that are innovators. Steve Jobs was an innovator. Innovators are people that can see the future before it happens. Quint Studer's an innovator. Those very few people that really can see ahead. Then you've got 13.5% that are early adopters. They see it, you've explained it, and they just go, I'm in. Let's go. Come on, let's go. Then in the middle there is the early majority and the late majority, so you finally have a tipping point. You're finally going to make things stick, if you will, because you've got enough people with you. Over here, 16% are laggards. Never changing, never going there, ever. Not going to happen. Cotter says that to really make change happen, the sense of urgency, 3 out of 4 of your leaders have to think that you have to make this change. 3 out of 4. So if I divided you all up in here, that means that 25% of you are going to say, we don't need to do this. That means the other 75% of you are going to have to carry them. My message is, don't be a laggard. Change is here. We're working. We've got to keep moving, and especially if you're a leader, you can't be a laggard. Here's what we go through, and it's something called transition, and it's such an emotional process. Most people don't really fear the change, but some kind of loss that comes with it. It may be that I'm going to lose some autonomy. It may be whatever that loss is. We have very typical reactions. You can see them up there. Grief, denial. What do you mean? This is really happening? It's kind of that whole thing of one thing is ending, and Bridges talks about those transitions in between. You're kind of in a neutral zone. You're ending being a student. You're going to kind of grieve that. No, I want to stay a student. Then I don't have to be responsible. But yet you want to. You want to go up on that other side of that transition. You kind of go through some chaos, and it's kind of I want you to think of this word frequently. I tell my kids this all the time. You know what? You're going through a very normal transition. I use that word with them all the time. And now they go, yeah, I know. But it's one of those things you feel better. This is normal. I'm stopping, leaving something, and going to something completely different. So change is very situational. Transition is psychological. Change is going to happen whether you want it to or not. And how you work through it in terms of your own transition is completely up to you. If you want to have successful transition, letting go of what's old and very familiar, I want to throw this out that please do not become a victim. And that's learned helplessness. Don't let change happen to you. Well, there's nothing I can do about this. All these people are doing all this to me. And when you're going through change, the time to be a victim is not then. There's never time to be a victim. But when you're going through change particularly, you want to be proactive. You want to know what's going on. You want to find out the information. You want to stay ahead of the curve and see what can you do to make sure that you really know what's happening. To adjust. Here's something else, too, that I think is really, really helpful. All of you in this room have gone through so many change experiences, let alone having children. Now, I had twins, so I had double the fun. And I know there's some twins, moms of twins. There's probably some triplet moms in here. And I used to always benchmark when my kids were screaming in unison that at least I didn't have triplets. So, it's all based on our experiences. You've gone through divorces, marriages, lost jobs, changed jobs, multiple experiences of change. We've gone through transition and we've figured it out. We can figure all this out. There's a lot of things in the literature today talking about resiliency. We all know how resilient children are and how as adults sometimes we lose a little bit of that. These are a few things I want you to think. Are you positive? Looking at this as whatever the change is, a new opportunity. Stay very, very organized. Keep your calendar up to date. Stay extremely flexible. Don't stay really caught in, well, I'm only a mother baby nurse. What can you do to advance your career, to be more employable? Stay very flexible. Focus. Stay very, very focused. And we see this often when you have a CEO change. Our CEO just left last July. And one of the great things she did and our interim CEO was he kept the whole organization focused with, your job is to make sure you take really great care of our patients. For us to spend a lot of time up in here of who's going to be the next CEO, I wonder what's going to happen. So when staff would ask me, what do you think? What do you think? I would constantly say, I think we're going to have another great CEO. We're not going to miss a step. Now I could have said, I don't know. I don't know what this means for any of us. I'm really scared. I don't know what it'll mean. And I could have had everybody's hair on fire, right? Because that's what leaders, we have such responsibility there. And lastly, stay very proactive. All right, I want to make sure you get this. Isn't that sad? Don't lead your staff over the grate there. I'm just kidding. During times of change, it is so critical that you have great leadership. It is more critical than ever. You have to, as a leader, stay very visible. You have to know that you're setting the tone. You have to know that your staff are looking at you for everything, every little nuance of what's about to happen. A couple of things. I want to go back to engagement. but employees don't want in a leader. The worst quality is arrogance. These are a few other things they don't want in a leader, particularly during change. Emotionally volatile, passive-aggressive, distrustful. They want to know that they can trust their leader. What they want right now is that their leader is very trustworthy, that they're inspirational. I was reading some competencies of great leaders during change, and that they inspire others. They keep people motivated, because at the end of the day, a leader has to let our staff know there really is hope. We're moving in the right direction. There's a compelling reason for this. You have to constantly, particularly as a leader, connect the heart and mind. Let me give you an example of this, because it's so important to me that you all kind of think along these lines. A few years ago, I have a very good friend. Her name's Corrie, and it's probably been 5 years now. Corrie has a very significant history of breast cancer, and she's always been very good about getting her mammograms on time, making sure she goes to have that done. She went in one day at an outpatient mammogram center. It wasn't Sarasota Memorial's, but she went in and she was 20 minutes late. She had gotten into traffic, walked up to the desk, and the registrar, if you read any of our information about ADET, talk about acknowledgement, introduction, duration, explanation, thank you. No one acknowledged her. The patient registrar didn't even look up, was looking at their, I'll just say their tasks, and said to her, "You're 20 minutes late, you'll have to reschedule." Being the compliant patient that she was at the time, she no longer is that compliant patient. She said, "Okay, sorry." Okay, sorry. We should be so glad that that patient picked us, let alone we just booted him out the door. Now, am I saying that every patient should be 20 minutes late? Of course not. She left. By the time she got her mammogram rescheduled through all of her, her job, her kids, she has 3 kids, through Ed, her husband, through all the things that were going on, you all know how that is. She got back about 9 months later for her mammogram. Anybody want to know what happened at 9 months? She had breast cancer. She had a double mastectomy. Would it have happened anyway? I don't know. Maybe. Maybe not. I don't know that. So I was telling Sharon Chambers, our director or our manager of all of our outpatient mammogram areas, I told her this story, and she said, "Oh my gosh, please tell me nothing like that's ever happened." She said, "I don't know if it has or not." Here's what a great leader does. She said, "I'm going to go back and have a huddle with every single one of my outpatient centers, and I'm going to tell them, this is what we do and why we do it." She went into this whole great big thing of, if a woman gets here and through all of the things she has to get through here, and yes, she might be 20 minutes late, but our philosophy is we're going to work her in. And the reason is because we're here to save women from dying of breast cancer, period. No matter if you're the registrar, whoever you are. You have to connect what we're really doing here. So we always want you to think about connecting the why first. If you always start with the what or the how, I would ask you to start right here today and start with the why. Why are we doing this? Why are we going to tell our patient that we'll work you in? Because we don't want you to have to come back and maybe have breast cancer. The leader's role in navigating through transitions is rounding, really asking your staff, talking to them. How are you doing? What are you thinking? How are you feeling? Thank yous and recognition, all of those things become very, very important. As great leaders, we want to assist those skeptics and the laggards. They're very often the last ones to adopt. They need us all to kind of bring them with us and say, you know what, it's okay. We can do this. That's what Johanna told our other labor nurses. It's not that bad. It's actually, I think you'll like it. We bring people along. So if you're a leader in here today, I'd like to ask you what you think you're really paid to do. And during change, I would tell you that some of your most important things you're paid to do today is to really help us transform healthcare and keep moving through all the changes that are ahead. What's the most important? Making sure that you choose tough over easy. One of those is having tough conversations. Highly reliable organizations are full of leaders that consistently coach others and have phenomenal role models. They're exemplary. And I want to go back to making sure you remember the biggest obstacle in achieving high performance isn't keeping that needed urgency for change. In change, you have to, as the leader, keep your foot on the gas, keep driving performance. I used to think when I first started in leadership that if we would just teach people how to do something, they're going to change, right? And who are the educators in here? Who are the educators? Educators. We have to teach what we're looking for, what right looks like. But what we know today after 15 years of doing this with the Suter Group is that it doesn't end there. That whole thing of how do you make change stick? The leader has to still be out there validating and recoaching every day. Because we're used to one way of doing things, and for have change, you got to revalidate it all the time. And the last word up here, if you can't see it, is reward. If you want different behaviors, you have to make sure you're paying attention and thank people for changing. Leaders have great influence, and if you're a leader in this room, I just want you to know that what is that? With great responsibility comes great, I'm not saying it right. It's probably a quote from the Bible. I'm probably not saying it right. What? Thank you. Thank you. We have such tremendous responsibility to your communities. Healthcare isn't, we're not making widgets. We have such ripple effect on our community. Great leaders are always looking for ways to keep your environment engaged, that great nursing environment, and holding staff accountable. So some of the things we talked about today, having a tough conversation, like I told you earlier, it's all about, you might know it, but are you going to go back out there today and do it? Are you going to execute? What do you really want in terms of a great culture? Today in healthcare, leadership is so important. You really have to have a plan because we know that things are changing so much in the external environment. These are all the things we talked about earlier that are changing. Anybody remember what this thing looked like, this typewriter? Anybody have one of those? Where you had to go like this? You guys wouldn't know what that looked like, but you had to hit the thing and it went back. And then you got white out, and I had white out all over the typewriter. And then you got that little thing where you could go back and correct it. And then we got to word processors, and today we're at computers. Would you ever want to go back there? Of course not. Was it kind of painful? Yes. But you wouldn't ever want to go back. What we think very much has remained constant in healthcare, though, is our passion. That connectivity, that I really still want to do this. If you don't know the difference you make every day in healthcare, you're not looking for it. Because I promise you, you have a place you can make a difference every single day. We have fortitude as nurses. That's why we do workarounds, right? We're going to make it work. We're going to be advocates for our patients. I want you to think back to your best leaders today. They are the ones that absolutely made you grow. They're the ones that challenged you. They're the ones that gave you feedback. They're going to be the ones that you guys will meet on the floor, and you're going to love them because they're going to make you better nurses. They're going to teach you. They're going to help you grow. If you want to talk about transformation, if you're a leader, or even if you're not a leader, you're an informal leader. When you talk about transformation, it's not this caterpillar turning into a bigger caterpillar. It's a caterpillar turning into a butterfly. And today in healthcare, we are right in the midst of so much transformation. I would ask all of you to be adult learners, to be students, constant students. Love, love, love this quote. A leader takes people where they want to go. A great leader takes them where they don't want to go, but they really ought to be. This is my mom, and I told you earlier that she had a heart attack in December. She had to have a STEMI put in. Came through our ER, our STEMI up to the cath lab, had 2 stents put in her LAD. First of all, I'm so grateful that our hospital is that, that we have all of these, I'll just say, protocols and best practices in place today in healthcare, because a few, maybe 5, 6, 7 years ago, she could be dead. I mean, she was sitting on a time bomb. I'm so grateful to our hospital, but I'm also so grateful to know that the people that I came in contact with at my own hospital were amazing. I didn't see a lot of low performers. I saw people that were very engaged and very passionate about still being there. And personally, I'm glad she's still alive because my mother is my hero. I hope that this is going to work. I'm going to show you a little video. I'm going to end here with a little video clip, and I want to cue this up. Some of you have seen it. But if you think that as nurses you don't make a difference, the future of healthcare is dependent on us. I want to show you a little video. It's got nothing to do with healthcare, absolutely nothing. It's about basketball. And this kid named Jason. It's a very old clip, but every time I see it, I love it. And I asked Regina, we talked about it, Jason has autism. So I want you to see this little clip, and I want you to know if Jason can make this type of a difference, the difference that we can make every day in healthcare. So I'm hoping it works. It did.
We had planned to bring you a story tonight about a kind of prep school that prepares football players for the NFL draft and big contracts. But we're going to call an audible. We're going to switch sports tonight because we've run across an absolutely amazing basketball player that we want you to see. Here's Steve Hartman.
Grace Athena High School in Rochester, New York has a new, most unlikely hero, a special ed student by the name of Jason McElwain.
Let's keep it going.
Jason is the basketball team manager. For the past couple years, he's been assisting Coach Jim Johnson, helping with whatever the team needs.
And go! Get him motivated and hand out water and just be enthusiastic.
Enthusiastic, to say the least. Despite being born with autism, Jason's father says his son has never had a problem expressing himself at basketball games.
You know, I was always concerned that he might get a technical and they lose a game because he, you know, start yelling or whatever.
Let's have a hard practice tomorrow, all hour and a half, and let's get ready for Arcadia. Let's go.
1, 2, 3, 2. Because he has been so devoted to the team, for the last game of the season, Coach Johnson decided to let Jason actually suit up. Not to play necessarily, just to let him feel what it's like to wear a jersey.
At least that was the plan. But with 4 minutes to go in last week's game, Coach Johnson stood up and pointed to number 52, Jason McElwain. After years of fetching water and toweling off other people's sweat, Jason was actually in a game. His first shot was a 20-footer from the right baseline.
Was it close? Did you almost make it?
I just airballed it.
I'm like, just, dear God, please, let's just get him a basket.
His second shot missed too, but the third was a charm. A three-point no-doubter. And Jason wasn't done yet. Not by a long shot.
If I wasn't there to witness it, I wouldn't have believed it, you know.
You caught fire.
I just caught fire. I was hot as a pistol.
Jason ended up shooting 6 3-pointers, one right after the other. He had 20 points total, and each time a shot went in, his teammates and the crowd went a little crazier. His last basket, right at the buzzer, created total mayhem. Because he is autistic, Jason says he's used to feeling different, but never this different. Never this wonderful. Steve Hartman, CBS News, Rochester, New York.
So what do you think? He was hot as a pistol. Wasn't that great? Love that. So if Jason can make that much of a difference, I always like to end with purpose and worthwhile work, and many of you have probably seen this, but just let me end with, our patients depend on us, and we certainly depend on you. Yours could be the first face they see when they come through the door, or the voice they hear right after a surprise diagnosis of breast cancer. Yours could be the eyes they look into as they're pushed in a wheelchair to a very frightening procedure. Your attitude, and I'll say your behavior, reflects us in everything we're proud of in this organization. You all have chosen to help serve patients, and personally, I want to tell you how much I appreciate you, how much you're doing to make healthcare better. Here's my parting thought to all of us. If you want to go fast, go alone. When my daughters and I graduated from college, we went on a trip last August, and they sleep till noon. So we didn't go very fast. But believe me, we went very, very far. We all have each other. We all have the opportunity to make healthcare a much better place. We're not doing this alone, but I know that all of you are doing something to make healthcare better. Thank you for having the tough conversations. Thank you for having courage. Thank you for being our nurses and our leaders of the future. I thank you all so much for letting me be here. I appreciate it. Thank you very much.
Thank you, Pam, for an awesome day and great information. I'm going to go home and practice on my husband on my difficult conversations. He's a good subject. Our last session today is back with Regina Holliday, who opened our day, and she's going to talk about the painting she has created from the conversations we've had today. So, thank you.
Okay, so this is a huge room and this is a little painting, okay? So you're welcome after this is all over to come up and see it up close, but I'm going to sort of describe the painting and to help you understand what it means. This painting is called High, Solid, Low, Tide because of the time and what's going on within your lives. Painting, as you look at it before you, you might notice, even if you're far away, even if you're in the back row, there are two color tones to this painting. It's split right in the middle. Because coming to Indiana, I had a lot of grief on Twitter yesterday. And there was a lot of different views that I was dealing with and a lot of explanations I was giving. And one of the things that I was saying is, you know, I firmly believe that everyone should have a seat at the table. I don't believe there isn't anyone out there that we shouldn't be talking to. Everyone is valuable, including everyone in the state of Indiana. And I was honored and blessed to be here. So in the very center of that design, I put your flag. And if you look at that flag, it seems to actually be pouring out as water out of a faucet that's coming above. It's one of those old-fashioned faucets with those handles that sort of look like propellers, okay? Because when we were hearing Pam speak, she was speaking about hand cleaning and how incredibly important it was, and how that is one of those campaigns we've all been working on. But the spigot of this faucet actually looks like a thimble. And it looks like a thimble because I sew. And I know a lot of people that sew. Many of them have the name Hirschberger where I live. And they all do something uniformly. They use thimbles, okay? Everybody I know uses thimbles because if you sew all the time, you know what you do. You prick yourself, okay? In healthcare, we ask people to wash their hands, but we don't routinely have a material called Skin Guard available for them. See, I know children who swim. They're on swim teams, and I know professional swimmers. And if you professionally swim, if you're in water all the time, there's a special kind of lotion that you're supposed to put on your body, or you're going to have skin breakdown. But I have gone to institutions all over this country where I've seen hospitals encouraging their entire staff to wash their hands 200 times a day without any kind of Skin Guard. And if you actually do that, you're going to have breakdown. So we can't do a campaign without making sure we deal with the ramifications of that campaign. Which brings us to those wonderful faucets and handles that look like propellers. The top of this picture is an airplane. It's a double prop plane. We have not done the best job of applying aviation safety standards to healthcare. Now, this past 2 weeks, we have seen blown up all over the news a story, and there's a reason why there's only one pilot in this plane. Because sometimes people make very, very bad choices. Sometimes those are mistakes, and sometimes they're purposeful. But we can learn from those mistakes, right? We have heard about this story about 149 people dying. And we know in healthcare that's nothing compared to hospital-acquired conditions and infections and how many those people die from those. But yet, we have morbidity rounds where we have closed conversations. The family's not invited. The caregiver's not invited. No one talks about it. We have hospitals that are in the same exact town, but they're not sharing each other's stories with each other. And we're not learning from those valuable mistakes. And I think Pam was trying to encourage all of you to become the kind of leaders who learn from them. If you look at the women and men in this painting, they almost remind you of drill team, cheerleaders, right? Isn't that the role you find you sometimes have to take? The one who's cheering people along, the one who's in between, the one who has everyone on your back. So in this painting, we have a patient on the back of a nurse, and we have a nurse on the back of a nurse. They may be high performers. They're way up in the air. And the patient, she has a darkened phone in her hand. And the nurse she is standing upon, he has a lit phone in his hand because he's answering that personal call. When Pam was talking and she said that, I thought, I did that too. I was at the toy store and my boss handed me a phone and I took a personal phone call in front of my customer. And it was one of the worst calls of my life. And we understand. We understand that sometimes you're not a nurse. You're a mom. You're a dad. Something happened and you have to leave right now. But we also want, when you can be with us, for you to be with us. I recently helped a friend of mine who's a patient with a diabetic episode she had. She's new to my area, and I know there's one hospital nearby that's pretty darn nice. I've heard they're great and they have excellent HCAP scores. So I took her to this hospital, and when we got there to the ER, there were signs everywhere that said, no cell phone, no cell phone, no cell phone, put it away. And I took a nurse aside. I said, you know, my friend, I'll be with her for a while, but she's emotionally compromised. She's going to need to be able to get her cell phone out because she's going to need to be able to communicate to me and other friends. So we need to talk about these signs. Oh, the nurse said, oh, those are just there because the doctors don't want people on their phone when they come in. They could be on the phone if she's very good about it. She does not show it to the doctor. We waited for an hour and 15 minutes before that doctor came in, and he came in for 3 minutes. If it wasn't a patient and caregiver situation where someone was advocating, there could have been a patient in that room alone, upset, sad, and sick for an hour and 15 minutes with no way to communicate to the outside world. Because there's people like my husband that obey the rules. So be very careful what rules you apply. If you look at the bottom of this pyramid of nurses, there are low performers. One of them is pointing up with this angry face. I think she's a lot like the person that you dealt with. But one of them, she's got her head bowed, and she's looking down, and she looks so sad. I think she's that third. I think we can help her. I think she's the one that you don't have to lose. So I want you to look at this painting and think about all these people and the people in your life that you're leading. And remind them, remember yourself, that there's high tide and there's low tide. There's good times and there's bad. But you as a leader will guide them in all times. Thank you.